Bismillahirrahmanirrahim. I am Dr. Osama, but I am a consultant gastroenterologist, hepatologist in Maroof International Hospital. I welcome you all to today's grand round session. First of all, I would like to condole our dear Madam Shagul for the sad demise of her mother. Inna lillahi wa inna ilaihi rajiun. My deepest sympathies are with Madam Shagul and her family. May Allah give her peace to the departed soul. Now, today's grand round topic is the evaluation and management of the three of the most common symptoms that the patient presents with a gastroenterologist. And these includes gas, bloating, and belching. So the usual patient comes to the family physician or gastroenterologist distressed with stomach gas and bloating, and certainly at that point he needs our help. So inshallah, in the next 30 minutes, I would be discussing about the journal definitions, what are the functional GI disorders, how do we generally classify these disorders, and then the evaluation, what are the preventive measures, and then a brief summary of how to manage these symptoms. Now, functional GI disorders are, as I've already mentioned, are one of the most common gastrointestinal complaints that are encountered. And among these disorders, the presenting complaint, the symptom of the majority of the patient, almost 10 to 30% of the patient, is abdominal bloating. And this abdominal bloating includes different terms. It includes excessive gas. Some patients present with frequent burping and some with abdominal rumbling. In a survey that was done in US, this was a population-based survey, of almost 16% of the population reported to have bloating, and among them, 3/4 had moderate to severe symptoms. So how would we define these three different symptoms? First, bloating. We generally define bloating as a sense of gassiness or of being distended, but it can be with or without visible increase in abdominal gut. It is basically a sensory phenomena in the small intestine and sometimes in the stomach also. It is not produced by excessive gas, but usually these patients have low pain thresholds and they have increased sensitivity. Second term that is most commonly used by the incoming patient is belching, which is expulsion of excess gas from the stomach. This may or may not coexist with bloating and distension, and in majority of the time it is due to excess of swallowed air. And it is often unrelated to the different causes that cause bloating. Similarly, flatulence is expulsion of excess colonic gas and is usually related to the diet intake. Our colon, that is large colon, is relatively insensitive to increased gas and distension. Therefore, whenever someone presents with excess flatulence, it usually does not cause the symptoms of bloating. Now, these three symptoms, which are a part of functional GI disorders, may increase with certain factors, which include maybe anxiety, a depression, any stressful life events, or with a history of recent illness, especially post-viral illnesses. And depending upon the presenting complaints, these functional GI disorders are separated into discrete syndromes, and each of them is diagnosed by specific criteria. It can be divided into functional dyspepsia, irritable bowel syndrome, and chronic idiopathic constipation. Now, this is a chart which shows the biopsychosocial conceptual model of functional GI disorders. So we are here, the functional GI disorder, the presentation has certain symptoms, it has certain severity and certain behaviors. And these presentation are dependent upon the psychosocial factors and the physiological factors. That is the intrinsic and the extrinsic factors. The psychosocial factors include the life stress, the personality traits, any psychological state, any coping or cognition changes, and the social support of the patient. And the different physiological causes, the intrinsic factors includes the change in motility of the intestine, the change in sensations, the immune dysfunction, any inflammation that is going on, altered microflora in the GI tract, and also much related to the type of food and diet we are consuming. And both these factors are interconnected by the central nervous system and the enteric nervous system. As we can see that both these two factors are in turn dependent upon the early life changes, the previous history of the patient, which include the genetics, the culture, and of course the environment, including any past history of trauma, any past history of infection, and also the parental behaviors. The output is that after this disease occurs, the output usually affects our healthcare use, usually affects our daily function, the quality of life, and the healthcare cost is dependent. Now coming to the evaluation of these functional GI disorders, the first step is to localize the symptom. As I have already mentioned, these disorders can start from the stomach, intestine, and the colon. So the first step is to localize the symptom. So we have to first ask two questions. First question is, can you eat a full plate of food? Whether you are able to complete the full plate of food or incomplete. And the second question is, do you regularly have a good bowel movement? And depending upon the response, these symptoms can be categorized as gastric bloating, small bowel bloating, bloating with constipation, and belching. And in the further slides, I will be describing these different symptoms one by one. Before describing these symptoms, first of all, I would like to tell about the alarm symptoms. Alarm symptom means that if any of these symptoms are present, then we have to change the track and we have to work on a fast track. These include any presence of abdominal mass, difficulty swallowing, extreme diarrheal symptoms including large volume diarrhea, blood in the stools, nocturnal diarrhea, diarrhea associated with progressive pain, and diarrhea which does not improve with fasting. Presence of fever is again an alarm sign. Presence of gastrointestinal bleeding manifesting as melena or hematochezia. If the patient has jaundice, he has lymph nodes. And most importantly, when the patient's age is more than 55 years and with the new onset of adenophagia, chronic pancreatitis, or with a history of gastrointestinal cancer, these are the alarm symptoms, and for that, we have to do further workup. This is the generalized figure of how to evaluate the patients. As we can see, the presenting complaints can be divided into gas and bloating with constipation, and belching. We will start with the gastric bloating. Now, gastric bloating is there when the patient presents with presence of gas and bloating, and the symptom onset is less than 30 minutes after the food intake. And it has certain differentials and further workup. So the gastric bloating is symptom occurring within 30 minutes after eating. The patient usually has inability to finish a meal, and the differential includes functional dyspepsia, gastroesophageal reflux disease, Helicobacter pylori infection, gastroparesis, impaired gastric accommodation, and gastric outlet obstruction. This is the usual algorithm that we follow, that the patient presenting with the symptoms of postprandial bloating, epigastric pain, or burning, we usually take the history. And if any of the alarm signs are present, alarm symptoms are present, we go for endoscopy plus biopsy. Otherwise, we go for empirical treatment with proton pump inhibitors. If we find any of the sign and symptoms, we usually treat it. Otherwise, we check for Helicobacter pylori infection, and if it is negative, it is known as functional dyspepsia. So the term functional dyspepsia basically includes two parts. It can either present with postprandial dyspeptic symptoms or present with epigastric pain syndrome. As you can see that in the first type of functional dyspepsia, the main presentation is bloating, early stitiation, patient has nausea, retching, bit of nausea, vomiting, and loss of appetite. As compared to the counterpart, some patients also present with major symptoms of abdominal pain and stomach cramps. This is the usual criteria which we follow in patients with functional dyspepsia. As I have mentioned, functional dyspepsia in endoscopy, there is no visible ulcer or erosions. So in functional dyspepsia, the diagnostic criteria is any one or more of the following: postprandial fullness, early stitiation, epigastric pain, and epigastric burning, and with no evidence of structural disease, including at endoscopy. According to different studies, this functional dyspepsia has certain associations with H. pylori infection. Although the evidence is unclear, but when we treat H. pylori, the result is that the functional dyspeptic symptoms in some patients resolve. So anyone presenting with dyspepsia, the strategy should be first test and treat with non-invasive methods, which include the urea breath testing, which includes the stool test, and also there is a minor role of blood testing, although that is a bit controversial. And if it is confirmed, we have to treat it. Similarly, functional dyspepsia has also association with acid secretion. So empiric PPI reduces the functional dyspepsia, and usually in these patients, we give a trial of anti-secretory therapy for especially patients who are H. pylori negative. The second differential that usually comes among patients with stomach bloating is gastroparesis, and gastroparesis is usually unrelated to mechanical obstruction. There is usually no mechanical obstruction, and the patient complains of nausea and vomiting, and it can be of different types. With the common types of idiopathic gastroparesis, which is more common in young or middle-aged women, and it usually develops after viral gastroenteritis, especially after the current COVID patients usually come with gastroparesis, and it usually takes a long time to resolve. And the second most commonly encountered patient are diabetic gastroparesis, although the percentage is very small, almost 1 to 2% of patients with type 2 diabetes, depending upon their glycemic control. So as I've been telling you, the different diagnosis, the differential points of gastric bloating include functional dyspepsia, the disorders of accommodation, gastroparesis. For that, we have to check for diabetes and recent viral illnesses. And then the gastric outlet obstruction also, we have to differentiate it with gastric outlet obstruction, in which the patient usually has vomiting or with a previous history of gastric ulcer disease. So in these patients, we have to do upper GI endoscopy. So the second scenario that comes with patients of small bowel bloating. Presence of gas and bloating, and the symptom onset is more than 30 minutes after eating. It comes under the heading of small bowel bloating. Again, it has certain differentials and further workup. So small bowel bloating is small abdominal distension occurring more than 30 minutes after eating. It originates in the small bowel and proximal colon. Among the differential, the most common is IBS, and the second common is functional abdominal bloating. And in this functional abdominal bloating, the patient usually presents with the symptom of abdominal pressure with or without objective increase in abdominal girth. So how do we initially test patients with small bowel bloating? We usually test for IBS, and for that we have to check celiac serology. We have to do colonoscopies. Especially we do colonoscopy whenever any of the alarm symptoms are present of the patient, or if the patient is more than 55 years of age. The second most common thing that should be differentiated or excluded is celiac disease. And for that, first the serology is done, TTG, IgA, IgG, also the AGA deaminated gliadin test. And if the serology comes out to be positive, it should be confirmed by the distal duodenal biopsy. We all know that the celiac disease presents with certain intestinal symptoms, diarrhea, weight loss, abdominal bloating, distension, and with certain extraintestinal symptoms, including anemia, the skin symptoms of dermatitis herpetiformis, some oral lesions, and presence of osteoporosis and osteopenia. The third differential that should be ruled out among patients with small bowel bloating is bacterial overgrowth. Small intestinal bacterial overgrowth. It has certain risk factors, including the certain structural abnormalities, presence of diverticula, small intestinal strictures, previous history of surgery, ileocecal resection. It is also associated with any disordered motility disorder, including scleroderma, presence of type 1 diabetes, use of opioids, and also with the chronic history of acid suppression. These present usually have small intestinal bacterial overgrowth, and they present with small bowel bloating. And as previously mentioned, two other differential include functional abdominal distension and bloating. Now, this small bowel bloating has certain association with different food sensitivities. IBS is the most commonly encountered, and IBS is usually excreted by milk or other dairy products, and this is because of lactose intolerance, which is due to lactase deficiency. According to a survey, almost 25% of the patients with functional GI disorders also have lactase deficiency, and this lactase deficiency can be congenital. It can be temporary, secondary to any episode of gastroenteritis, after any parasitic infections, and also common among patients with iron deficiency. But this thing should be kept in mind. We know that in lactose intolerance, there is a lactose in the small intestine along with the low activity of lactase. It enters into the colon, and then this lactose, which has not been broken down, is attached with the bacteria in the large intestine, which results in fermentation and increased gas production and certain symptoms of bloating. Now, coming to the third category, that is constipation with bloating. So we have discussed gas and bloating, among that gastric bloating and small intestinal bloating. Now the third category is presence of gas and bloating with constipation. So it certainly has certain differentials, and again differential workup. These patients usually present with difficulty or incomplete bowel movement and typically have either IBS-C, IBS, idiopathic bowel syndrome, constipation type. It can be functional constipation. It can be dysynergic defecation or slow transit constipation. So I would like to go to the chronic idiopathic constipation, that is IBS constipation. Especially in order to diagnose IBS constipation, we have to rule out dysynergic defecation. And for that, we have certain tests. We have certain history points, history of incomplete evacuation, straining with defecation, manual movement of stool, and with a history of sexual or physical abuse. The common causes which we usually ignore during history taking is the history of secondary constipation, which is due to the presence of hypothyroidism, history of diabetes, neuropathy, hypomagnesemia, hypokalemia, and hypercalcemia. So we have to inquire about the different medication intake, including calcium-containing NSAIDs and iron supplements. Dysynergic defecation, this is a pelvic floor dysfunction. And as I've already mentioned, it should be ruled out by anorectal manometry and careful history taking, especially digital rectal examination. So for dysynergic defecation, first step is to do the rectal examination. Patient lying on the left side. During inspection, we have to rule out presence of any fissure, external hemorrhoids, or any other perineal abnormalities. With palpation, we have to confirm the presence of fissure, any tenderness, any mass, stricture, rectocele, or presence of hard stool. And then there is a small test known as anal wing test for the checking of the perineal sensation. There is also a bearing down test, which is usually done during defecation, and it usually tests the descent of perineum, that is usually around 1 to 3.5 centimeter. More than this descent, the likely cause is prolapse. Now the fourth presentation is belching, expulsion of excessive air, and it can be divided into gastric belching, supragastric belching, and aerophagia. Belching is because it prevents the gas accumulation and distension, and it typically occurs 20 to 30 times daily. And the different types are gastric, supragastric, and aerophagia. The gastric belching is likely because of rapid eating and gum chewing, and which may cause excessive air swallowing. The lower esophageal structure relaxes with each belching. In the supragastric belching, the lower esophageal structure does not relax with belching. And the diagnostic criteria is that the patient who are belching during conversation, worse when they are discussing their symptoms, and better when they are distracted. So this is supragastric belching. And then the aerophagia is because of any anxiety, rapid eating, gum chewing, and excessive air swallowing. The reason is that. Now, whenever we are evaluating patients with these symptoms, especially patients with functional GI disorders, the most important step is history taking. And history taking among these patients is very important because it helps to establish effective relationship to diagnose the different, categorize the symptoms, and to evaluate in a structured approach. The patient should be satisfied that after history taking, he understands that there are certain biopsychosocial model of functional GI disorders. Patient should be confident that the evaluation of the other conditions has been adequately done. He should know that there are certain limitations of therapy. The symptoms will improve in incremental fashion, and the patient should be engaged in effective self-management. During history taking, the most important step is establishing a trusting relationship. First, we have to acknowledge the patient's symptoms, and the patient should be asked in detail about the chronicity of the symptom, the waxing and waning of symptoms, the temporal relationships, the precipitating or aggravating events, any history of recent illness, and any psychosocial stresses. During history taking, the dietary history is also very important. Among that, the timing and patterns of meal, any large or less frequent meals, any gulping of food, poorly chewed food, and also importantly, the content of food, any presence of gas-producing foods in usual diet, artificial sweeteners, caffeinated or carbonated beverages. So as we can see in this slide, whenever there are artificial sweeteners, it usually results in bloating and often with diarrhea. Similarly, use of caffeinated beverages, coffee, soda, result in belching and diarrhea, but less likely to cause bloating. This is because of it decreases the lower esophageal structure pressure. Excessive use of carbonated drinks leads to excess gas and bloating. The different dietary eating habits I've already mentioned leading to belching, bloating, gas. Use of over-the-counter medications, that history should be very importantly asked. Presence of taking NSAIDs containing magnesium leading to diarrhea. The size and timing of meals eating late in the day leading to bloating and distension. And a specific type of food, the bloating forming foods, which cause gas formation. Now coming to the treatment of these disorders or functional GI disorders is divided into different categories. First is the treatment of the factors in the intestinal lumen, then the treatment of bowel wall, neuromodulation, the brain-gut axis treatment, the CNS drugs, and the psychological therapies. We'll be discussing each one. Before starting treatment, reassurance about the benign course of disease should be done with the patient. And the presence of anxiety, depression, and any stresses usually increases the symptoms. So that should be kept in mind. Usually among patients who have self-management, combination of medications and dietary interventions, then these are most effective in almost 50% of the patients. 20% will develop new symptoms. Coming to the first category, the intestinal lumen, the first thing is the diet. The patient should be counseled to eat in moderation, do regular exercise to decrease the symptom of IBS and chronic idiopathic constipation, decrease the consumption of fatty and spicy food, avoid caffeine, soft drink, carbonation and artificial sweeteners, and giving certain probiotics which improves the symptom of bloating, gas and pain. These are the different foods which have hidden lactose, and as I've already mentioned, almost 25 to 30% of the patients with the symptom of IBS has underlying lactose intolerance, and these food include biscuit, cake, processed breakfast cereals, cheese sauce, cream soup, custard, milk chocolate, pancakes, scrambled egg. So whenever patient presents to us, any gastroenterologist, the first thing is that we ask the patient to decrease their intake and to see the response maybe in the next 2 weeks. Then we can restart if there is no improvement, or we can do further workup. Now, there are certain foods which are falls in the category of food map diet, and these food map diets are usually shown to increase the symptom of IBS. And this includes the food map means fermentable oligosaccharides, disaccharides, monosaccharide, and polyols. And these may precipitate the symptoms in certain individuals. So in patient with IBS, the second step is to give the low food map diet, the food which contains less food maps. This is a slide which is showing the high food map diet. Oligosaccharides are usually present in wheat, onion. Disaccharides are present in dairy product, cheese, milk. Monosaccharides, honey, apple, pears, mangoes. Polyols and apricot, peaches, and galactose in lentils and green beans. So this is a chart which is usually given the low food map diet, the food which can be taken, the vegetable, the carrot, cucumber, fruits, strawberries, pineapple, grapes should be taken. Maybe we can avoid blackberries, watermelon, not for a long time, at least we can check and then we can continue if there are certain symptoms. Similarly, among the proteins, a patient can take chicken, but avoid breaded meat. Similarly, among the fats, they can take peanuts, oil, butter, but avoid this almonds. And certain starches, the gluten-based bread should be stopped, and then the patient should be followed after 2 weeks. Again, there are certain gas and bloating forming foods which should be kept in mind, especially when someone presenting with these symptoms. Patient should be asked to avoid these food and then let us know the response. These foods we all know commonly include cabbage, cauliflower, bean, apple, milk, onions, potatoes. Now coming to the medical treatment, the intestinal lumen increases the fiber, which can be the soluble fiber and the insoluble fiber. The usual fiber increase, it should be increased gradually, because if we suddenly give a lot amount of fiber, spagol or certain other things, it usually cause bloating and distension. The dose should be increased gradually. And if there are worsening of gas and bloating with the use of fiber, then the dysenergic defecation, that the pelvic floor dysfunction test should be done to rule out this disorder. Osmotic laxatives should be used, including polyethylene glycol. It usually comes with the name of Maroof call. Is one of the most effective way of treating chronic idiopathic constipation, and other laxative, osmotic laxative include lactulose, sorbitol, occasional mannitol. As I've mentioned, PPIs, proton pump inhibitors, are recommended. Empiric therapy is recommended among patients with functional dyspepsia who are H. pylori negative or who remain symptomatic even after H. pylori eradication. Now coming to the different drugs that are acting on the bowel wall, it includes the opioid agonists. Loperamide 2 to 4 milligram up to 4 times daily basically decreases the colonic transit time in IBS diarrhea. Different anti-spasmodics can be used. Hyoscine, daclomine or peppermint oil are usually used. Similarly, for the bowel wall, we can use the stimulant laxative, which include Dulcolax, but again, the duration of Dulcolax therapy should be kept in mind. Prokinetic agents includes the Maxilon, metoclopramide, and Buspirone. The Bus comes in the name of Buspar, 5 to 10 milligram, 3 times daily, but it usually acts as an antidepressant and relaxes the gastric fundus. Then there comes the role of brain-gut access medications. Among the most studied one is the amitriptyline tryptanol. Usually start with 10 milligram at bedtime, and we increase the dose by 10 milligram every 1 to 2 weeks. It is usually very helpful among patients with diarrhea, predominant IBS, and also among patients with functional dyspepsia. Again, it's the third category medication. The certain psychotropic drug, the SSRIs, and then there comes the role of psychosocial therapies, cognitive behavioral therapy, and hypnotherapies. So coming to the summary, the different recommendations, the functional dyspepsia, IBS, and chronic idiopathic constipation can be diagnosed using symptom-based clinical criteria. The first thing should be tested for H. pylori, and eradication therapy is positive, should be used for the initial evaluation of dyspepsia without alarm sign in younger patients. Patients with diarrhea, predominant or mixed presentation IBS symptom should include testing for celiac disease. Empiric PPI is moderately effective for treating functional dyspepsia in patients who are H. pylori negative or who remain symptomatic even after H. pylori eradication. And highly restrictive gluten-free diets or diet restricted in food map can be used in IBS management. Thank you very much. I'm ready to answer the questions if there are any.
जी, अस्सलाम वालेकुम डॉक्टर ओसामा. Thank you for your presentation. I joined a little late, but मुझे एक क्वेश्चन है कि क्योंकि आजकल गट माइक्रोबायोम का बहुत बड़ा रोल है in neurodegenerative disorders and several other conditions की pathophysiology में, तो ये जो एजेंट्स हैं, प्रोकाइनेटिक एजेंट्स हैं या दूसरे जो एंटीकोलिनर्जिक्स हैं या एंटीस्पाज्मोडिक्स हैं एंड ऑल दैट, ये गट माइक्रोबायोम पे कोई इनका कोई प्रोलॉन्ग्ड यूज से कोई इफेक्ट होता है या इनमें ये दे आर न्यूट्रल एंड दे आर नॉट लाइक प्रोबायोटिक्स और एंटीबायोटिक्स इन डिफरेंट डायरेक्शंस? इस पे कोई रोशनी डालेंगे?
Sir, initially I have mentioned about the use of probiotics. वो इसमें basically slide में से miss हो गई कि use of probiotics in the initial end पे मैंने medicine बताई हैं. But again, the prolonged use of PPIs or the prolonged use of even prokinetics tend to increase the concentration of bacteria and leads to the small intestine bacterial overgrowth. So the first step always in the management is the diet control along with the use of certain probiotics. And after that, we tend to increase the, there are different stepwise management, including the PPIs, prokinetics, antidepressants. So always the first step should be the diet management and the addition of probiotics.
तो डाइट मैनेजमेंट में और प्रोबायोटिक्स में लोकल फूड्स के लिहाज से आप मतलब यूजुअली व्हाट यू सजेस्ट समथिंग लाइक मतलब कोई खास कोई फूड प्रोडक्ट्स हैं या कोई ओवर द काउंटर कोई प्रोडक्ट्स हैं पाकिस्तान में जो फ्रीक्वेंटली यूज हो सकते हैं? बिकॉज दिस इज ऑब्वियसली अ कॉमन कंसर्न स्पेशली एल्डरली लोगों में, फैमिलीज में एंड ऑल दैट. तो ये ऐसी चीजें रहती हैं, तो व्हाट डू यू नॉर्मली रेकमेंड टू दिस काइंड ऑफ पीपल?
अच्छा, बेसिकली जो पेशेंट जो प्रेजेंट करते हैं उनको मेजॉरिटी में जो फर्स्ट आते हैं तो मैं सबसे पहले उनको 3 चीजों की प्रिवेंशन का कहता हूँ कि आपने 3 चीजें अभी एटलीस्ट 2 वीक्स के लिए आप उनको लीव करें एंड लेट मी नो द रिस्पॉन्स देन. वो 3 चीजें होती हैं। सबसे पहले मैं उनको कहता हूँ मिल्क प्रोडक्ट्स, कहता हूँ मिल्क प्रोडक्ट थोड़ी सी कम करें, क्योंकि ऑलमोस्ट विद एज वी टेंड टू डेवलप लैक्टोज इंटॉलरेंस। तो सबसे पहले कहता हूँ कि दूध और इससे बनी हुई चीजें थोड़ी सी कम करके देखें। इसी तरह चाय में दूध थोड़ा सा कम करें, ग्रीन टी ज्यादा करें, फिर देखें व्हाट्स द रिस्पॉन्स। सेकंड थिंग जो मैं कहता हूं कि आप बेकरी प्रोडक्ट्स जो हैं, डिफरेंट बेकरी प्रोडक्ट्स, उनकी क्वांटिटी का इंटेक कम करें, स्पेशली द व्हाइट फ्लोर, उसकी चीजें, व्हाइट ब्रेड, जो नान और इस तरह की चीजें, आई यूजुअली टेल देम टू रिड्यूस दो। यू कैन टेक द ब्राउन ब्रेड, यू कैन टेक द जो फुल ग्रेन wheat, we can take that, लेकिन ये चीजें कम करो। थर्ड जो चीज बताता हूँ वो the content of sugars in your food. For example, any cold drinks, any juices, the amount of sugar in your tea, for example. तो सबसे पहले ये 3 चीजें मैं लेफ्ट करवाता हूँ। उसके साथ I ask the patient to increase their fluid intake. For example, you have to take 2 liters of water. You have to, मतलब again with the certain history के renal failure वो ना हो, cardiac वाली, लेकिन at least 2 liters water intake. Along with that, थोड़ा सा इसपोगोल हस्क लेना शुरू करें, along थोड़ा ल्यूक वार्म वाटर में इसपोगोल हस्क, और इस तरह की चीजें, और फिर इनका रिस्पांस देखते हैं। और सर्टेन प्रोबायोटिक्स, एनी ऑफ द प्रोबायोटिक्स, टेक डेली योगर्ट हैज सर्टेन प्रोबायोटिक्स देन, एंड अ सर्टेन कोई भी प्रोबायोटिक, आइदर यू कैन स्मेक्टा और एनफ्लोर। तो ये कॉम्बिनेशन 3 चीजों की रिस्ट्रिक्शन एंड 3 चीजें बढ़ानी है, एंड देन लेट मी नो द रिस्पांस इन 2 weeks, and then we can continue depending upon the other symptoms कि अगर gastric symptoms है, we can check the gastric symptoms, H pylori और other symptoms। अगर colonic symptoms हैं तो उसमें पे हम certain test कर लेते हैं। लेकिन जो dietary modification are these 3 things जिसको मैं usually follow करता हूँ। और usually patients come with a lot of response. Even if I don't give them any medication, they usually come back and they said that they have almost resolved almost 60% of their symptoms. So it has usually very good response.
Thank you so much, Osama. Inshallah, I'll come and see you in 2 weeks.
I am very really thankful to you all for giving me this time, and Allah Hafiz from me. Thank you, Zoe, for all the arrangements.